That's the dinner bell. Good afternoon, everyone. For those of you still getting food, there are lots of seats up here kind of toward the front, so come on in. We're going to get started so we can stay on time today. Thanks all for being here. My name is Zach Boone. I'm the City Club Board Chair for 2025. We are thrilled you're here today to listen, learn, and engage on this topic that's clearly so important to many in our community. This is the largest City Club forum we've had since COVID, so thank you. A quick reminder, let's just actually see, how many of you, this is your first City Club ever? All right. Our membership and sponsorship team will be in touch. No, in all seriousness, thank you for coming. Whether this is your first and last or you want to join the organization, this is what we do. We try to bring the community together for important topics, and I don't think anything could be as important as this as we head into 2025. We're really mindful also of the busy event calendar that's out in the community. We've tried out some different times and formats this year. Last year. We're going to be doing that again next year. So as we come into this year, look for breakfast meetings, afternoon meetings, this traditional lunch format, but we hope that helps you make it to City Club forums that are a little bit different, and we're going to change up the location as well, although the UU is pretty great. So thanks again for the Unitarian Universalist Fellowship for hosting us. As always, we're thrilled to be here. Today's forum title is The Changing Business of Healthcare in Central Oregon. As you know, we also plan the next time we do a healthcare forum, we're going to have it be in your MyChart. You can just register there. So look for that. Thanks. That's my joke of the day. And I want to say thanks to the Central Oregon Health Council. They are our sponsors today. Let's give a great round of applause to Central Oregon Health Council. I can tell you that COHC does a ton in the community, from these kinds of sponsorships also to big grants, the college where I work as a recipient, so I really appreciate all the work COHC is doing. And again, to all of our sponsors who've been rotating on this slideshow that you've seen today, thanks to all of our sponsors. Let's give a round of applause for all of them as well. So without further ado, I will introduce our moderator, and we'll just jump right into the program today. Kat Mastrangelo is the Executive Director of Volunteers in Medicine, a free clinic for the uninsured, which serves Deschutes, Crook, and Jefferson counties. Prior to working at VIM, she managed specialty medical practices, worked in local government and hospital management, and in the health insurance policy at Anthem Blue Cross Blue Shield. She has lived in Bend for 22 years and is active on the boards of the National Association for Free and Charitable Clinics, the Central Oregon Health Council, the Lund Report, and the Oregon Health Forum, and most importantly, a board member for City Club of Central Oregon. Please welcome Kat Mastrangelo.
Good afternoon, and thank you, Zach. And as our panelists are making their way up, I'll go ahead and introduce them. So start with Nicole Ramos, who serves as East Cascades Regional Economist for the Oregon Employment Department. Her main responsibilities include conducting data analysis, research, and writing on labor market issues impacting workers and employers in our region. Nicole also provides tailored labor market information and analysis to support businesses, clients, and economic development partners in making well-informed decisions. Before this role, she held the position of workforce analyst in the Mid-Valley region. Next is Mike Bonetto. Mike is the co-founder and partner of Tenfold Health. He has a unique portfolio of over 20 years of healthcare strategic planning and policy experience. He was previously chief of staff and senior health policy advisor in the Oregon Governor's Office, where he helped lead the transformation of the state's Medicaid program. Prior to that, he served as vice president of business and community development at St. Charles Health System, senior associate at Zoom Care in Portland, senior vice president of planning and development for Clear Choice Health Plans in Bend, director of the Oregon Health Policy Commission, senior policy advisor to the Oregon State Republican Caucus, and policy analyst for the Oregon Insurance Pool Governing Board. And finally, we have Seth Dugan Knight, who is the legislative director for the Oregon House Majority Office. And he was previously chief of staff to Representative Ben Bowman, where he helped write H.R. 4130, the legislature's first attempt to close loopholes in Oregon's corporate practice of medicine doctrine. Before that, he was chief of staff for Representative Rob Nasi and then chair of the House Healthcare Committee. Seth has focused on healthcare throughout his career as staff in the state legislature, and he is here today to speak on what Oregon hopes to achieve in regulating the corporate practice of medicine. Is this on? Our forum today on the business of medicine, it seems like it's ripped from the recent headlines, but in fact, the genesis of this forum and this conversation began as just that. It was a conversation following one of our City Club program committee meetings. As any group of people of a certain age will do, the conversation turned to medical procedures. And one member raised concern that their upcoming joint surgery was in limbo. They had been scheduled in the upcoming weeks with a provider from Desert Orthopedics, and the practice had abruptly closed. They didn't know where their doctor could be reached, and they had not gotten information to know where to go or what to do. Someone else chimed in that they knew someone else in the same situation, and somebody else. And then, as any good program committee members did, we realized that if this many people in this small a group we knew were directly impacted and wanted some answers, others might well too. So we decided to do some research and start this conversation. Before we get to our speakers, I want to share some statistics regarding our health service area. So we are served here in Central Oregon by a sole community hospital system with 4 facilities: St. Charles Bend, Redmond, Madras, and Prideville. The system serves an area roughly the size of South Carolina, but South Carolina has 109 hospitals in that same area. St. Charles dominates the region in employment with 4,791 employees and a payroll of over $633 million. Other large medical groups in the top 50 private employers include Summit, Mosaic Medical, Pacific Source Health Plans, Best Care Treatment Services, Central Oregon Radiology, the Center, Partners in Care, and Praxis, also known as High Lakes. Just these top 9 medical groups employ 7,579 people. And that doesn't even include all of the surgery centers, the smaller specialty practices, dental offices, and other services like accountants and attorneys that we need to support all of that work. So it's really fair to say that healthcare in Central Oregon is a huge economic engine. How all this gets paid for is really important. St. Charles receives about 70% of its revenue from government programs, and by that I mean Medicare and Medicaid. That is much higher than many other hospitals, and it has implications for financial stability. And in the Tri-County area, OHP has really expanded, and now 75,000 people are covered by OHP in the Tri-County area, and that includes 25,000 children and 50,000 adults. You know, we often think of Central Oregon as driven by recreation and high-tech entrepreneurs, but if you live here long enough, even if you never go skiing and you never stay in a local hotel, chances are you will at some point need to see a doctor, and you will probably be admitted to the hospital at some point. So our topic today, it really impacts all of us. We are saving time at the end for questions and answers, and I encourage you, as we're continuing this discussion, if you have questions, to write them down, and we will have time for that at the end. Okay, so Nicole, we're going to start with you. You have prepared some really informational slides, and starting with the first one, the population pyramid. It's not really a pyramid, is it? And can you tell us about that and why that's important?
Absolutely. So I'm going to talk about a couple key demographics here that are likely to affect access to care. And like you said, it's population size and growth and population age. In 2023, for instance, the population of the Central Oregon area was estimated to be around 252,000, rounding up. And 93% of the population in Central Oregon is insured, right? When we talk about insurance, that's a difference from 81.9% of individuals insured a decade ago, so 2013. Currently, most of the insurance is health is private coverage as opposed to public coverage. We have 67.5% of people living in Central Oregon that have some kind of private coverage or in combination with some other coverage. And that is up from 63.6% a decade ago. Now, when we talk about public coverage, that also has increased. We have 41.9% of individuals in 2023 in Central Oregon had some kind of public coverage or public coverage in combination with some type of other coverage. And that's up from 32.6% in 2013. Now, if we break it down by age, what you get is the pyramid of which you're seeing right now. And what this is saying is that 34.7% of the population in Central Oregon is 55 years or older, right? And that's Central Oregon. And this pyramid is actually very indicative of the population in Deschutes. If I were to take Crook County out, for instance, they're a bit top heavy. So they actually have of older population. 40% of the total population is 55 years or older in Crook, with a median age of 47.7. Compare that to the state's median age of 40.7, or Deschutes, which is 43 years old, around there. So what I'm trying to get at here is that there's a problem, and the problem is twofold. The older we get, usually the more medical services we're going to require, or the more health services individuals are going to need. So the question now becomes whether or not we as a region have the labor force that is needed to meet the healthcare demands of this aging population. Because as the older population continues to increase, so does the share of individuals 55% and older that are actually in the labor force. And that presents a different problem. So the share of individuals that are or will be of retirement age within the next 10 years is actually...
Yeah, can we get the next slide?
Oh yeah, sorry, next slide. Sorry guys, I'm just talking. So the problem is also, because we have an older population, our labor force is actually also getting older. As of, I believe it was 2023, in Central Oregon, 23% of all jobs were held by workers ages 55 and older. And that has been increasing over time. But with that, what's also been increasing over time is the amount of individuals not in the labor force because of retirement. Right, so what I'm saying is that the share of older people in our workforce is increasing, and they're also retiring more than before, right? So, in fact, the long-term trend that you're seeing there, we see is that the share of workers considered in their prime working age, so 24 to 54 years old, that has actually been decreasing from 72% in 1992 to 63.9%, while the share of 55-year-olds has actually been increasing from 9.3 in 1992 to currently 23.1% in 2024.
So does that mean we never get to retire?
I hope not. I'm looking forward to retiring. So now, next slide, please. One might think that okay, well, with strong population growth, that could help us make up the labor force losses that are happening because of these retirements and because of natural population decrease. But not necessarily. So let's consider two scenarios. One where all net migration just stops. Let's just assume that in the future no one's coming in, right? So if in that scenario, what we have is the current numbers. If we look at our current numbers, deaths outpace births. So the population would not meet our population replacement levels to sustain our current employment, let alone within the healthcare industry, where demand for services theoretically is going to increase despite our population. If our population doesn't increase, that means nothing for demand on services because we have an aging population, right? And this is not to mention any research that might indicate that younger individuals are having more autoimmune diseases. So this is not even considering all those other factors. Now the second scenario is the scenario you see here is the scenario where we do actually have population growth through net migration. And although we have more deaths in the region than births, we have been relying on this net migration for our population, but that is set to actually, the rate of growth is set to decrease, right? And really, all these individuals that are coming in, they represent new clients. That's what they represent. As the larger population means that a larger number of individuals will need more access to care. And what I really want to highlight is that these people in no way equates to a stronger workforce. Having these individuals does not equate to a stronger workforce. Next slide. And essentially, it's because you are competing with all these other industries, right? So workers are spread thin. Once you adjust for things like population size, industry training, stuff like that, your pool of workers just became more narrow. And you're competing with all these other industries. And the questions such as, okay, are those skills from these other industries, the individuals in these other industries, how transferable are they to our industry, to the healthcare industry? Many times, you're gonna see that they're not so transferable. We're coming from trade, transportation, where most individuals tend to go into that industry, and leisure and hospitality, which do not necessarily have the same requirements and education levels needed as the healthcare industry. So these, next slide, please, become very important. And what we're left with is an estimated 0.043 healthcare workers per resident in Central Oregon. And by 2033, if we assume the population growth rate of 1.4 after the estimated population of 2030, these ratios are set to decrease even further. So what I guess I'm saying is that the aging population and a growing population represents specific challenges for the healthcare industry as far as meeting that demand that both of those things will eventually require, and should be thought about in these terms. Even if we are seeing growth within these occupations, the growth itself may not be enough to sustain the demand.
Wow, that's a lot to think about. And we will publish these slides. We can put these on our website. So if you cannot read those numbers because you're older like me and you need glasses, then we will have that. So thank you, Nicole. So Mike, based on what we've just heard and maybe learned on the changing demographics, we wanted to talk a little bit too about just what's happening at the national, at the state, and then in local trends in healthcare, and more specifically, how some of those trends are impacting our access to physicians and providers.
Sure. Thanks, Kate. Can we bring up that slide that had the one graph of the trend line? I guess my first thing, Nicole, after hearing you and thinking about the demographics and thinking where I fit in those demographics, I'm feeling pretty damn old now, right? Holy cow, yeah, that one. I'm gonna hit on this because this is a huge trend across the nation. It's a huge trend here, and it's impacting a lot of access issues. But I'm gonna break this down and maybe into 3 buckets. So the first one just being overall healthcare reimbursement. It has changed dramatically over the years. So we've seen healthcare provider rates, I would say, stay stagnant or even not keep up with the growth of overall inflation. So from the hospital level, from the physician level, everybody's been impacted, and that has had a huge impact in terms of how you operate a clinic. So that has been a big piece. The second piece of that, though, is that we have had a change over the last 10 plus years in the way care is paid for, that we like to think of things being paid for more of value. How do we pay for a value-based payment? So what does that look like? Well, from a hospital perspective, if we discharge somebody, we want to make sure that they actually have a successful discharge and transition into their home. So we've changed the payment model so that if that individual comes back to the hospital within 30 days, the hospital many times won't get paid for that, right? So it's a change in terms of how we think about that, so it actually increases the value of those dollars we're spending. Good, but it also changes the way a hospital has to do all of its preparation for any sort of discharge planning. So if you think about that on the provider side, think about a provider who is caring for diabetic patients, right? So they have a panel of patients who are diabetic, and instead of just treating them over and over and over again, we now have kind of changed some payment models so that those providers are incentivized to keep those patients what we would consider well managed, that their insulin blood levels are within an appropriate range so they're not having to access the emergency room or go back to their clinics time and time again. But again, for a smaller clinic, mid-sized clinic, that requires a lot of data, a lot of infrastructure, a lot of reporting, and more importantly, more like a team-based approach to providing care. So it dramatically changes kind of that entire environment. So as we have reimbursement rates sometimes declining or staying stagnant, we're asking those clinics to actually do more and have kind of these significant outcomes. So that has placed a big challenge on clinics. So we have kind of this overarching reimbursement as a challenge on access. That has then led to what Nicole was just talking about from a provider shortage. So yes, we have this significant increase in retirements and provider shortages, but a lot of it has been due to what we're seeing on that reimbursement side. The Oregon Health Authority, so the state agency over in Salem that oversees a lot of kind of healthcare delivery and policy, just came out with a report this month that showed healthcare workforce continuing to decline. So on a per capita basis, we're still seeing kind of access to primary care has gone down. More significantly, gone down in rural areas. So you think of La Pine, Madras, Prineville, all of those are significantly more impacted than we are here even in Bend proper. So again, we've got this provider shortage, a lot due to some early retirements that have happened, but people just getting out of healthcare because it's not as viable as it once was. So that has then led to kind of a third variable, this third bucket, that would be around kind of consolidations and acquisitions. So we kind of have from a reimbursement to a shortage to then saying, okay, now what are we going to do? If a clinic is really struggling financially, they're going to look for some outside kind of financial assistance to do that. And we've seen this migration more towards how do we improve, how do we get better economies of scale kind of across multiple clinics. So this element of consolidation and acquisition is taking place at an incredibly fast pace right now. And some of you may have heard of a company called Optum. Optum's a bigger healthcare company, but they are a subsidiary of United Health Group, right? One of the biggest healthcare organizations in the nation. Optum right now, you may not know, is the single largest employer of physicians in the nation. So roughly 90 to 100,000 physicians are under the Optum umbrella, make up about 10% of all physicians in the US. We've seen Optum move into Oregon. I know Seth is going to be able to talk more specifically about that, but from Portland to Eugene to Salem, right, we've got a lot of activity, even in Corvallis. So that has really started to take a different shape, and some pros, and I would say certainly some unintended consequences that, again, I think we'll hear more from Seth on, that can really upend a community. Right? It can impact access, it can impact costs, it can impact a number of things. And so there's certainly some concerns, and I think the legislature is now really starting to look at that in more detail. Second question?
Wow. So second question, well, yeah, so all of these national trends, are they showing up here in Central Oregon? What are you?
Yeah, I think so we're not immune to any of this, right? And we have all of kind of our local practices are still kind of having to deal with those same issues. And we have seen it play out here in Central Oregon, and many of you, I'm sure, get care at Summit. Before Summit, it was Bend Memorial Clinic, our largest multi-specialty clinic in the area. And they, over the last couple of years, have partnered with Summit Health. Summit Health Management is a company that's based out of New Jersey that has done this across the nation in terms of trying to partner with other mid-sized, larger clinics to provide them the resources and infrastructure that they need. And I would definitely want to have this be a big takeaway, that when you think of those types of acquisitions, and we hear private equity, we hear some sort of acquisition, many times it's a red flag and we think of something negative. And I would just caution that. It's not all the time. Do the safeguards need to be put in place? Absolutely. But if you really look at what has happened even with Summit, they now have produced probably some of the best health outcomes that we've seen across the region. They actually have probably some of the lower costs and have helped improve overall access. So in terms of them getting an infusion of resources and actually have some expertise to help change that structure, they've done an outstanding job, and I think they've, for the most part, have been a strong community partner. That has not played out in every community, right? And I think we certainly need to be vigilant around how that takes place, and I think you're going to hear from Seth in more detail about legislation that is really trying to put those safeguards in place so that if there are future acquisitions, how do we kind of allow those physicians to be empowered to kind of maintain that decision-making authority and not turn that over to kind of a third, out-of-state party.
Great transition. So Seth, thank you so much for coming all the way over the mountains to join us today. I know it's a really busy week in Salem and a couple of months coming up. So I've heard there are a record number of bills that are being introduced this session, and many of them are going to address healthcare issues, everything from mental health to dental reimbursement, workforce development, public health, the list just goes on and on. But you're here today to talk about the Corporate Practice of Medicine Act. So tell us more about that and how it could impact us here.
Perfect, thank you. And I want to just kind of cover what the corporate practice of medicine doctrine is, because I recognize not everyone might be familiar with it. Oregon and more than 30 other states have laws on their books mandating that medical clinics be owned by physicians and other licensed independent practitioners, so NPs and PAs. And these come out of the 1930s and 40s in the US, when you had railroad and mining bosses hire what were called company doctors, whose role was to get workers back out as quickly as possible. And the federal government and the vast majority of states at the time recognized a conflict of interest and a challenge with the patient-doctor relationship when it was allowed to happen, and enacted these bans. That kind of runs contradictory to some of the trends we hear about, where Amazon owns clinics in Oregon, Optum owns clinics in Oregon, Praxis owns clinics in Oregon. So how those two things come together is kind of an interesting area for public policy and an area of concern. I'll give an example just because it helps to kind of quantify how this works. When I learned about this, I looked into Amazon. Amazon owns One Medical, which is a series of clinics in other states and in Oregon. Amazon cannot own One Medical. That would be illegal in Oregon. But they do own a company called One Life Healthcare. One Life Healthcare is an MSO, and I promise not to use too many acronyms, but that is a management service organization. What this used to be, apologies if you couldn't hear me. Management service organization used to be something a clinic would hire to do administrative work, to do billing, so doctors could spend time with patients and not be stuck up doing a bunch of paperwork. That has changed for a number of MSOs. One Life Healthcare is just one example, but if you read the filings in Oregon, the terminology that's used is One Life Healthcare is, quote, doing business as One Medical. And that's a good way to think about how that structure works. They need to have a clinic in order to operate in this state, but the decision-making, the authority, the control rests with that MSO. That's the corporate vehicle. And there's some repercussions that go along with that I'll get into. One stat I want to mention, because I've learned it in this process and it's stuck in my head since then, is that there's been a 100,000% increase of private investment into primary care since 2012, from 15 million to 16 billion. It's a sea change in how people are perceiving this industry and how that works, and that is largely through this MSO model. And I think it's worth asking why all these entities, from private equity to insurance companies and Amazon, would want into this business when you hear from providers, and I think Mike laid out very clearly the challenges of operating in this space. There's a lot of providers being forced to close down because it's difficult to keep doors open. And one other piece of relevant data, private equity firms that are buying in this area, they usually aim for around a 15 to 25% annualized rate of return on their investments. How you can achieve that in healthcare is a really challenging and interesting question. But there's a bunch of levers you can pull if you own a clinic that we don't regulate. The most prominent of which is you could stop seeing Medicare and Medicaid patients. Doesn't reimburse high enough, you can make more money by not seeing them. You could say to the physicians at the clinic that you run, you have to see 30 patients a day, not 15. We need to get more patients in the door. You can also regulate that each issue has to have a separate appointment. So you come in because you're having issues sleeping because of back pain. Back pain is one appointment, issue sleeping is a second appointment. And you can make sure you get reimbursements that way. You can close down low-performing clinics. You can say you have a clinic in a rural area that's mostly serving Medicaid and not having enough patients. We're not going to operate that anymore. And I think to people in this room, and at least I think to most of us, those sound like really harsh and cruel decisions that we would not expect folks in the provider community to make, and most of them do not make. But it's the difference between that decision being made locally in communities by medical providers who are balancing a duty to patients with a need to make money, versus being made in the boardroom of a private equity firm, where not only do they not have the duty to patients, but they have a fiduciary duty to return value to their shareholders. And that changes that dynamic. That is just me theorizing about what people might do. I want to make sure I'm backing this up with some actual data. So the New England Journal of Medicine had a 2022 report on corporate medicine in which they said it results in higher costs for patients, worse outcomes, and higher provider burnout. I'll give one statistic because I think it signifies the problem very clearly. When private equity buys a hospital, we see around a 12% rise in low-risk C-sections as opposed to other hospitals. That stat, what it shows, when you have a C-section in the hospital, there is more reimbursement that goes to the provider, and there is more money flowing to that system. That is an example of the ownership of that hospital influencing the decision-making of the provider in that setting, which is exactly what the corporate practice of medicine doctrine was set out to prevent. So the question underlying that is, does our corporate practice of medicine doctrine, which is still the law of the land in this state and the majority of other states, need updating to ensure that we're continuing to protect against this trend? I think it's also helpful to talk about what is happening locally, and Mike, you touched on it. Just to name a couple examples. Over the mountains in Eugene, Optum, which is owned by United Health, which I think had $23 billion in profits in 2023, bought the Oregon Medical Group, which was a longtime provider-owned entity based in the community. After purchasing it, I think around 2 years later, half the physicians that worked at that clinic left for a variety of reasons, and over 10,000 patients got letters in the mail saying you don't have your primary care provider anymore. Now, I want to mention non-competes were a part of that departure, and I should be very clear that Optum has waived those non-competes in that situation, but that crisis is ongoing to this day. Just north of that, in Corvallis, 2 years later, Optum bought the Corvallis Clinic, also provider-owned, based in the community, now owned by Optum. In Portland, Optum owns several clinics. And another example that stands out there, Sound Physicians is a private equity-backed anesthesiology group that has a contract with Providence. They came in promising to speed up timelines and be more efficient. Instead, they were unable to recruit the physicians they needed to provide care, and surgeries were delayed 2 to 3 months, creating an access crisis immediately there. I'm a little less familiar with the situation here in Bend, but I have learned a number of examples here, and I know that there are a number of major players, but here there has been issues with praxis, clinics going under, and non-competes, and providers leaving the community and people losing access to care. And so one piece I want to underscore here is we're not standing still deciding whether we should embark on a change. There is a change happening under our feet, and we're deciding whether we should react to it. And there are risks to action, but there are also a lot of risks to inaction. And a quote that stuck in my head from former Governor Kitzhaber is that the wholesale purchase of Oregon's healthcare infrastructure is well underway. And I think that is true and relevant to this discussion. I want to touch on what the bill itself would actually do, and there's a number of nuances, and I won't get it too deep into legalese, but the core thrust of the bill is to regulate specific decisions that have to stay with the clinic and cannot be made by the MSO and must stay with medical providers, and that list is based on decisions that would impact clinical care, trying to make sure that we cannot allow whatever the owner is to impact clinical care. I want to be very clear, this bill would not ban investment. Private equity firms could still invest in clinics in Oregon. Amazon could still invest in clinics in Oregon. They already cannot own those clinics. That is still the law. They could invest in them, but they must be provider-owned. One thing you will hear if you engage with this bill, and I hope some of you will engage as it goes through the process, I'll say in 2024, it came within one vote of passing, but just failed. It'll be back in 2025. One piece you will hear from opponents of this bill is that it could deter investment. We could see investors have higher risk in their investments and therefore not want to invest in Oregon. And I think that is a valid concern that I want to name, but I want to say 3 things that I think are relevant to that concern. One, the rate of investment in this area, 100,000% increase since 2012, shows that we could probably slow that rate down slightly, still be doing okay. And a lot of the claims about access and the risks we might take, as I just mentioned, are already happening. This is not a situation where we can avoid that risk. But third, and I think most importantly to this bill and to this conversation, is would you want an investor to own clinics in your community if the only reason they're willing to have that investment is if they can control the decisions of providers? If that deterrent is enough to drive an investor from investing in a clinic, that itself should be a red flag about what that would mean for care in this community. And I think that's a core piece of this conversation. I'll leave it there.
Wow. Okay. So we do have some time for question and answer, and we have a couple of volunteers that have microphones. Where are the volunteers? Can you raise your hands? Okay, great. So if anybody has questions, just raise your hand, and we're going to ask that you identify yourself. And stand if you can, so we can hear you better. And if you want to direct the question to one of the specific panelists, you can do that. And we'll take as many questions as we can. Remember, a question ends with the question mark. So if you have your own piece to say, let's talk to you. Maybe we'll do another forum for you, okay? So thank you. Okay, go ahead, Emily.
Hi, I'm Gen Z. I've asked a lot of questions at these meetings, but my wife just graduated from PA school last month. Very exciting, but thank you. But what I'm wondering is, we talk a lot about the greed of private equity, of businesses. What are we doing about I hate to say it, but the greed of these colleges, that my wife had to take out $200,000 in student loans for a 2-year program. And that's not, and she's on the low end because I can like help her because I have a full-time job. A lot of people had to take out more. So is there something that this community or the state could do in order to like help stop that burden that's placed on these young people at an early point in their life?
Yeah, so that's a great question. So, Nicole, I mean, just the cost of education for people entering this workforce as a barrier to entry. Do you have any thoughts on that?
Yes. It is definitely a barrier to entry. More so when we're talking about how that cost relates to wages, right? When we're thinking about like healthcare support jobs, for instance, which I think are going to be, as far as this industry goes, are the ones with the most job vacancies, right? So there's a need for these workers. Sometimes we forget that the support system required for the industry, for the healthcare industry, so these healthcare support workers is actually quite large. But if we look at their median wage, for instance, they're making $21.55 an hour, right? Is that livable? Is that livable in this area, right? Where you know, to own a house, can they own a house? Can these individuals own a house in Bend? Probably not at $21.55, right? Even the average, which is a little higher, is $23. So when we're talking about that as a barrier, it's definitely a barrier because we see it in our job making surveys that the healthcare support jobs are consistently on the top of difficult to fill positions just because of the education requirement coupled with the wage that they get. So when we talk about lessening the barriers, the discussion needs to be had about like, okay, what do we do as an institution? Shall we start training in-house instead of at school, right? What does that look like? Are some of these requirements, some of the educational and training requirements, can we actually, lessen them, not make them so stringent? And these are important questions that you guys are all going to have to ask as the demand for services continues, but the labor force either decreases or stays constant in this industry anyway.
Kat, one other thing I would mention, I think it's worth looking at, certainly for rural areas. We do, if statewide, have a rural provider tax credit and then also a loan forgiveness program. Both are specific line items within the state budget. They are not funded nearly as well as they could or should be, and I think that is something that I think there should be kind of more advocacy around that to kind of help individuals like your wife. Yeah.
Is that on the agenda, Seth, for this
I
session?
will say that Representative Bowman is working on a bill including expanding student loan payments specifically for providers in rural and in other underserved areas. I think we absolutely have to act on this. The trend is unacceptable. I will also say that this trend ties into the trend of people going into corporate medicine because fewer people want to own clinics. If you graduate with tons of debt, it's not feasible to open and operate your own clinic. And so those two trends are directly linked, and if we don't solve both, we aren't solving the problem.
Great. Okay, got a question up here. Okay, oh, Janet, okay.
Here we go.
Okay.
Fun story, I did hospice for 2 years up in the valley. I joined them in July 22, 9 competitors. When I left 20 months later, 14. 4 of those 5 new entrants were venture capital based. So, question. Being in that industry, so you talked about the exit due to retirement. So I guess in terms of like mental health and professionals. So you had people that had to deal with COVID, but one of the things that we just couldn't keep nurses, one, because they were the sandwich generation. So they were having to take care of their kids, but they had to leave to take care of their parents. But all the stress and everything when they left, they just didn't want to come back to that environment. So I guess there's somewhat like wanting to retire, and then there's kind of a forced retire. But I guess from a mental health aspect, how are we addressing it? I know, Seth, you mentioned mental health bills and stuff, but I got to imagine that's for a general population. What are we doing for our healthcare practitioners?
Yeah, and so OHA just came out with their workforce report. I think they released it this week, and that is one of the topics that they talked about were how can we talk about social determinants of health, but they had a concept called social determinants of work. So are there bills around that? Are you guys familiar with that report? Any thoughts on that?
Well, yeah, the report just came out, right? But I think there's a lot more that's been focused on around provider burnout. And certainly COVID played such a huge factor. We lost, right? I mean, a huge chunk of the workforce during COVID. I think there's been some elements around best practice to address provider burnout. So I think you're starting to see that more in some clinic settings around what they're doing around kind of well-being and mental health. But I think we still have a long way to go, for sure.
I'll say I'm through reading around 1,200 of the 2,600 bills that have been filed for the session that starts on Tuesday, so I can't speak to everything. But there is absolutely work around this. And I think one piece that I'll just mention that ties into this conversation is we see higher physician burnout depending on who owns and runs the workplaces and what the priorities are within that workplace. But I think a big part of this is also ensuring we have the workforce to deal with the level of demand we have so that we don't have overworked people in these areas. And I think we've focused on wages, and there's been a big increase in how we pay out behavioral health rates in this state, but there has to be a conversation on workload as well.
I just want to add that as far as wages goes, the healthcare occupations are some of the highest paid, in fact. So when you start realizing that our job vacancies are, that the healthcare still maintains the highest number of job vacancies and they're still the highest paid, obviously there's something going on that's not just money, and that's this possibly mental health equation at play, right? People don't want to. They're like, no, if I go there, it's going to be hard. So, yeah.
I'll just put a plug in for Volunteers in Medicine. And we have seen this, and we've done surveys with our volunteers to show that people go into medicine because they want to help people, right? And then they get into it, and the reality of it is not always the same. And so sometimes they'll take a break, and they'll come to our clinic, and they'll work in a different type of system and get back in touch with what it is they went into medicine for. And they're able to keep licensure and to stay active, and then a lot of times go back into the workforce. And sometimes they're looking for not a full-time job. They're looking for part-time. They're looking for flexibility. They have families. They have, couples that are working. And so when we talk about these social determinants of work, I think that's going to be a really important concept for everybody. We've definitely seen it. Okay, question over here.
Hi. I'm already a loud talker. I'm Kelly Kincaid. I work in the functional medicine industry, and I really appreciate this whole conversation, especially around short-term treatment options. And I guess one of my questions is what percentage of the costs and needs of our current healthcare crisis here is determined by preventable lifestyle diseases and such like that? And then also, what can we do in terms of legislation and local prevention of these diseases and education to people to reduce the need for these healthcare costs that we're experiencing?
Great question. So, Mike, I would think you know those stats.
I don't have all the numbers, but I mean, there's been a lot of research over the years that, we know 10% of somebody's well-being actually comes maybe from the healthcare system, 90% outside of that, right? So we've known that. We've started to change a bit of the model, right, in terms of having the healthcare industry start to tackle what we call social determinants of health with modest success because we're not necessarily equipped to deal with those elements. I think we're starting to explore different things. I'm looking at kind of folks from the Health Council and folks doing things on the Medicaid side where we're trying to go upstream and focus on housing, on nutrition, on transportation, things that we haven't necessarily done in the past. At the same time, that has triggered a lot of provider burnout, right? So you're now tasking a provider to say, hey, I want you to treat this patient, but I also need you to kind of evaluate all of their other social needs and help them kind of get access. That's a completely different model that we're still, I think, learning and trying to adapt to.
I would just credit Mike and former Governor Kitzhaber and Dr. Goldberg with, I think, pioneering this model in Oregon of trying to focus on social determinants of health. I think there's a lot of work to be done to fine-tune and increase the kind of best practices, but clearly that work has started here and it hasn't to this degree in other states, and I think that's important that we've started this work and need to continue and really invest in it.
Thank you. That was a great question. All right, back here.
Hi, I'm Lou Capozzi, a City Club member. You talk about worker shortages in healthcare. Welcome to America. Try to get your car fixed. Try to get your teeth cleaned. I mean, we have worker shortages everywhere. The New York Times editorial on Sunday pointed out that we have an enormous issue of worker shortages in America. Their editorial was about immigration. And what they said in their editorial was, instead of deporting them, give them a path to citizenship so that they can help alleviate the worker shortage. And so my question to you is, what will the mass deportation program do to the healthcare industry?
So, Nicole, I'm gonna toss this one to you, but I'm gonna couch it a little bit. So thank you, Lou, that's a great question. But how, do we know in the employment statistics how many of the people in these healthcare jobs are immigrants, and what part of healthcare in general is done by immigrants and recent immigrants?
So I don't have those stats with me, and at the end of the day, there's no way to know what will happen if we start mass deporting, specifically, like in that one case, right here, given all the conditions. But I will say that in one of the scenarios that I gave you it was zero net migration. So we just relied on our natural increase or decrease, and that's basically this situation if that were to happen. Let's say that we don't get any new people in, right? We're basically in a situation where now our labor force will continue to decrease, but our aging population is still going to keep aging, right? They're not just all going to disappear from one day to the next. So in this scenario, it would actually increase the burden on the healthcare system, because we know that the available pool of workers for the healthcare system, once we funnel it all down, once we account for all those variables like age, like geographic location, all these, and for industry-specific skills, then it's very, very little the amount of workers available for the healthcare industry, right? And one of the slides I showed, so considering our current projections, with our current projections and our projections for employment, then that worker to individual ratio will decrease even further, and it's already very, very, very small. So I would predict that it would not go so well.
Okay, next question. Okay, Emily.
There we go. Hi, my name is Lisa Flexner. I wanted to point out something and then ask a question, if that's all right. We seem to be conflating mental health with burnout with moral injury, and those are three different things that require three different ways to address it. Mental health is inherent to the individual. Burnout is an interaction between individual and organization. And moral injury is more about the larger system and things coming down from public policy. So if we're trying to address these issues where we have 67% of healthcare professionals across professions considering leaving their job, and about 37% planning on leaving the profession entirely, how do we manage the interventions at the appropriate levels, whether through legislation or through organizational impacts? And also, how do we make sure that we're including not just physicians and nurses, but the entire healthcare field?
Yeah, that's a great question. And in the beginning, when I talked about some of our larger healthcare organizations, and they have hundreds, close to thousands of employees. Yeah, do any of you have any idea what some of these systems are doing internally to help their own employees, or is there something we need to be doing more as a community for support? Any thoughts?
One that may not be the most popular. So when we talk about kind of the burnout, we talk about kind of the current situation and even reimbursement and understanding we have this limited number of healthcare dollars, right, to distribute across our system. Much of the problem that we have today is because of our own expectations, right? We want instant access, we want the best care, we want the best technology. All good. It all comes at an extraordinary cost. It all comes with amazing sacrifices. So there has to be some sort of understanding around what we actually want to see a future healthcare system look like. and what our expectations are going to be. If we're going to continue to have kind of what we expect to see, we don't have the resources to continue to do that. So we are really having to look at what are different models of care, right? So we can actually do telehealth. We can do kind of more team-based approach that actually can make things more efficient and actually lower that provider burnout and kind of overall stress on the system. We, again, have a long way to go there, but a lot of it is kind of reflected upon all of us around how we view kind of our interactions with the healthcare system.
And are there any examples of somebody who's, of an organization or a state that's doing that well?
I mean, I think, again, I would say Oregon has taken some proactive steps with the Medicaid population. There are other states from New York and North Carolina, Washington have all done some similar work of really trying to be proactive in addressing kind of people's needs so that we can actually decrease their healthcare needs over time. But I think at the same time, all of us kind of in the non-Medicaid space, again, we have certain expectations that we have been ingrained with kind of over the years. And I think that is going to be a fundamental change that we're going to have to address.
I would maybe just add, and I don't mean to sound like a broken record, but I do think we see higher rates of burnout of providers depending on who owns and controls the decision-making at these companies. So if we have organizations whose primary goal is to have a higher rate of return, the workforce is going to suffer. And I think we have to acknowledge that as a part of this, although not the entire solution, and there are organizations that can do better that are run by providers too.
Okay, Janet?
Yes, my name is Rita Pearson. I have two concerns. I was just at a clinic yesterday, and the women at the desk scheduling appointments and stuff commented they couldn't schedule me out 6 months because they have physicians leaving that they haven't replaced yet. And when they schedule an appointment, they have to have a doctor to put with that appointment. So they told me, call back in a month. And they said that there are no regulations about insurance. I don't know if that's just in Oregon or national, and pharmaceuticals, so that they can set their own rates of what they decide to reimburse a clinic. And they said it's just not sustainable. So that affects them, even they're not the doctor and whatever, they're trying to do their job and feeling very, very frustrated. The other concern I had, I was curious how much our high cost of housing here affects your trying to recruit people to fill these jobs. Thank you for being here.
Yeah, so kind of two questions there. Number one, I mean, just a very pertinent example of day-to-day access to providers, and if we're losing providers, then what are we going to do? We've only got a couple of minutes, but if we could just talk about, so housing, we've touched on a little bit, and how hard is it to get people in Central Oregon because of the cost of housing, or is that all over Oregon, or are other places with low cost of housing, do they have lots of doctors?
Housing is definitely a deterrent, right? So the housing department came out with a recent study, and a healthy economy, usually an individual will pay between 3 and 5 times their annual wage for a house, right? In Bend alone, it's 6.5. Which is much higher than the states, I believe 5.5 or something like that. So if you're one of those workers and you're making $21 an hour, if you're one of those support workers, if you're not a physician making, $100,000 every couple of months or something like that, I don't know what they make. Well then, housing is almost unaffordable if you live in here. You have to commute in from Crook, you have to commute in from Jefferson, and again, commuting is a deterrent. Right? How long is it going to take you? These are all factors that individuals are going to be calculating in their cost analysis of whether this is worth it with this position. If I would make 20, why not just work at McDonald's down the street from my house, and all I got to do is wake up and walk over, right? So definitely housing is a deterrent.
Any other comments on that one before we wrap up?
I would second that. But the other piece that you highlighted in terms of just even your access issues, I mean, I think that is indicative of what we're seeing across everybody. And the concern is that becomes what we sometimes call a death spiral, right? We just have more physicians leaving, and it's just harder to replace, and we just kind of keep going. Thus, then we have this vacuum for kind of the corporatization of medicine, which we're trying to kind of, again, what are the safeguards that we need to put in place for that?
Well, we're at time now, so if you have other questions, we do have an ability to send those to our website after, and we would love to see those. Hope you have enjoyed this, learned a little bit about the demographics, why some of those big trends are impacting healthcare right here in Central Oregon. And then I also hope as a call to action that you'll educate yourself on some of these bills that are pending in front of the legislature this term, and reach out to your elected officials and let them know what you think about it. So thank you, Nicole and Mike and Seth, and we really appreciate your being here today.
Everyone, just a good thank you to Kat for being our moderator today and leading our team in bringing this topic. I also want to give a shout out to the rest of the forum team, Daisy Lehman, Alondra Johnson, and Kathy Sabatier for bringing this all together and bringing this topic to our community. Just a reminder that a few of our Bend City Councilors are in the gathering hall, and they're going to hang out for a little bit if you want to stop by. They're looking for feedback from the community on goals that the council should be focused on. They're in their goal setting period right now, so if you have a moment and want to, they're at a table in the back. And reminder that next month's forum is on February 20th. We'll be talking about artificial intelligence. As you can see, we have packed houses for the last 3 forums, so register early to ensure you get a seat, but we hope we'll see you on February 20th for our forum. I know that there's a lot of new people to City Club here, so if you have questions about City Club, as Zach said, a membership or sponsorship committee member will be reaching out to you, but we're happy to chat with you as well if you have questions. Thank you all again for attending. Thanks to our panelists. It seems like we have a lot more to talk about on this issue, so hopefully we'll see you again in the future. Thanks everybody, and have a great afternoon.